levels of prevention today. So you might not have seen that. But if you haven't checked them out yet, just go to Doc Sharing and listen to them. And they pretty much kind of give you a brief overview of what those are. Those are going to be important concepts that are going to come up pretty much on every exam that you have. So that's kind of like the basis of the course. So what is public health? Public health is a scientific discipline that looks at epidemiology. And we'll talk about epidemiology in much greater detail later on in the course. It looks at statistics, assessments. It pays attention to behavior, to culture, to economic factors, as well as program planning and policy development. The goal of public health is basically to organize community efforts, and that'll use scientific and technical knowledge to prevent disease and promote health. So pretty much what we're trying to do is, yes, we take care of the sick, but we want to try to prevent, people in the community from getting sick, right? Public health is what members of a society do collectively. So what we do together to ensure that the conditions exist where people can be healthy, right? So we're making sure that we have grocery stores in the community, right? We don't want what are called food deserts, where people don't have grocery stores and they're pretty much getting, their sustenance from like the gas station or a corner store and things like that. We want to make sure that they have like parks and places that are safe for them to go outside and exercise and be active in the community. Some benefits from having public health over the last few decades, because we didn't always have a public health system. But since it's been implemented, we've noticed a dramatic increase in life expectancy. The current life expectancy is almost 79 years old compared to 69 years old back in the 60s. Women typically live a few years longer than men do, so just keep that in mind. There's been a decreased number of deaths from stroke, coronary heart disease, and cancer as well. There's been a decline in the death rates of both adults and in children. All right, so when you compare the population-focused public health approach, when you compare that to just medical intervention alone, up to 70% of early deaths in America can be prevented. Early deaths are considered, or premature death is considered anything that's less than 65 years of age. And then you compare that to only 10% decrease in death when you're just looking at medical treatment. So if we can prevent things from happening, we can save a lot more lives than if we, say, are treating people who are already diagnosed with an illness. All right, so despite public health being funded by only a small portion of the healthcare budget, the practice of public health has provided a lot of benefits and it saves a lot of money. So to summarize that, basically, when it comes to funding from the government, we don't receive as much as other areas of health, but the benefits from public health kind of outweigh and outdo the other areas, if that makes any sense. So imagine if we actually allocated more money to public health, we could actually end up preventing a lot more illnesses and death and diseases. The public health core functions. So these are the 3 core functions. Make sure that you understand these. The first one is assessment, right? So as nursing students, I know that assessment is not new to you. This is something that's been drilled into your head, right, since fundamentals. So in the case of public health, we're not assessing the individual, we're assessing the community as a whole, right? So we're monitoring the population's health status and making that information available about the community, and we use that information to make decisions on how to care for the community. After you've done your assessment, then is your policy development. So based on the information that you gathered from your assessment, now we're going to look at, okay, what is the community missing? What do they need? And then we develop policies based on that. And then finally is your assurance. This is where we make sure that the community has everything that it needs, right? We've done our assessment, we've done our policy development. Now we have to make sure that the community has what it needs to exist. And we also want to make sure that we're providing a competent public health workforce as well. Because if you've done your assessment, you've done your policy development, but then we haven't done anything to ensure that the community has what they need from our assessment and our policy development, then we've fallen short. Any questions about the public health core functions? Okay. These are some essential services of public health. And if you pay attention, you'll see that the key action words presented here are like monitor, diagnose, educate, research. Those are the kind of like the basis of public health. These are the kinds of things that you're going to be doing. And if you notice, again, you'll see some of the nursing process in there, right? You have your assessment, your diagnose, your planning, your implementation, evaluation. Okay, so public health nursing is population focused, right? So again, we're not, we work with individuals, yes, and we'll talk about that when I explain community-based and community-oriented nursing in the next slide. But we're more so focused on the population as a whole. So the main goal is to have the community free of disease and disability. The main way that we can do this is to ensure satisfactory living conditions. One of the things that we do is we assess the community, and we'll also talk about that as well. Let's see here. One thing to remember, as you can see, population, and then I have here, or aggregate. Population and aggregate are synonyms. We can use them interchangeably, right? So they mean the same thing. So what exactly is a population? How would you define the term population? Anybody want to take a stab at it?
A group of people.
Mm-hmm. Right. It's a collection of individuals. And to add a little bit on that, those individuals share one or more personal characteristics, or they share environmental characteristics, right? So they either live in the same place, or maybe they are the same nationality or the same culture, or what have you. Then you have your subpopulations, right? So you have a population, and within a population, you can have another population, right? So an example of that would be, okay, you're in your community. Let's say you live in Miami Lakes. That's a population. Then if you want to break it down even further, people who are senior citizens in Miami Lakes, that's a subpopulation. People who have special needs, that's a subpopulation. Maybe people who are homeless, that could be another subpopulation. So within a population, you can always break it down even further and to have a smaller population of people. Okay, now to community-based and community-oriented nursing. So in community-based nursing, remember that the focus is on illness care. So we're caring for people who already have some sort of disease or injury or something like that. In community-oriented care, the focus is on preventing something from happening, right? Going back to community-based, let me break it down each one for you first. So again, community-based is illness care. We're focused on people who have diseases. We're usually working with people one-on-one, right? So we're doing some sort of healthcare service for them. And we're working with individuals and families. In community-oriented, we're focused on promoting quality of life, preventing things from happening. We're usually working with people in larger groups, and we're usually providing indirect care. So we're not providing any kind of like skilled nursing care or anything like that. So an example of community-based nursing would be like your home health, right? Because we're in the community, we're not in a hospital setting, we're in the community. We're working with someone one-on-one, and we're providing them with skilled care. Community-oriented nursing, the best example of that would be like your health fair, some sort of educational program at a recreational center in the community. So you're not really working with people one-on-one, you're working with them in a large group. Of course, you could always work with someone one-on-one, like if you find somebody within the group that is at risk and they need a little bit more attention, you can work with them one-on-one, but the goal is to work with people in groups, okay? Any questions about community-based and community-oriented? Okay, if you do, let me know. And again, listen to the video and doc sharing, and that should help to clear it up a little bit. I think most people understand the differences between the two because they're kind of like opposites, but it's just remembering which one is based and which one is oriented. So just try to come up with something maybe that will help you to remember that. All right, and then we have the levels of prevention. I just want you to focus on the primary, secondary, and tertiary, right? So in primary, the goal is to protect people from developing a disease or from getting hurt, right? So these are your things that you're going to do for, as nurses. Remember, we always educate, right? So education is always a perfect example of primary prevention. Immunizations, vaccinations, that's another thing, right? So like getting your flu shot or getting your MMR immunizations, those kinds of things to prevent you from getting a disease or illness. And then the third example of that is legislation or laws, right? Sometimes we don't think about that, but we do have laws in place to help prevent us from getting hurt. Think about wearing your seatbelt, right? That's a law that's in place to protect us from becoming injured if we're in a car crash, or requiring, I think children under like 14 or 15 or so, they have to wear a helmet when they're riding their bike by law. It's not something that you really see enforced, but it is there. It is in place to help protect children from having head injuries if they, were to fall off of their bike. Other laws like stopping people from smoking indoors, that's another law that's in place to help protect people from getting sick. And then we have secondary prevention. The goal with that is early detection. So anything that is like a kind of a screening, monitoring, those kinds of things will be secondary. So doing blood pressure screenings, blood sugar screenings, those kinds of things that you see at health fairs, going to have a mammogram done or a colonoscopy. So basically the difference between primary and secondary is primary is we're trying to stop you from getting it to begin with. We don't want you to get it. Secondary is you could have it or you could not have it. We don't know. So we're doing some sort of test, some sort of screen, some sort of evaluation to find out if you do. Because if we can detect it early, then we can prevent, we can probably cure it if it's something that is curable. Because we know that there are some things that if we catch it early, we can cure and reverse. And then there are some things that if we don't, it can progress and sometimes even become fatal. And then finally, we have tertiary. Tertiary is basically designed to limit the progression of a disease or disability, right? So if you have that patient that already has diabetes, they already have hypertension, whatever it is, most times we know that that's not something that is reversible. That's something that's going to last with them for a lifetime. But our goal is to make sure that it does not progress, right? So for example, people with diabetes and hypertension, we know that they're at risk for damage to their target organs, right? We want to make sure that we protect their eyes, their kidneys. If they're diabetic, we want to protect them from losing their limbs. So we're going to do things to help prevent them from getting worse. So we want to make sure that they're going to see their primary care provider on a regular basis, that they're taking their medications, that they're exercising, that they're doing all the things that they need to do so that they don't get worse. Okay. Any questions on levels of prevention? Okay. All right. So just to talk a little bit, just to close out this chapter, um, providing care in the community is good for a number of reasons. One is that it costs more to treat people in a hospital setting than it does in the community, right? So we can save money by treating people in the community. Also, people prefer, to be in their homes. Nobody really wants to be in a hospital. So if the patient is stable enough to get care in the hospital, then that's probably going to be the best environment for the patient. It's more appealing to the client if they're in their home than if they're actually in the hospital. We do expect this trend to grow as we're trying to fight rising healthcare costs. So we do expect to see more care in the community as the years, go on. And I'm sure where you live and work, you've probably seen like a lot of different centers and stuff being built to provide care more in an outpatient setting versus in an inpatient setting. Okay. Anybody have any questions on chapter 1? Okay. So next we're going to look at chapter 12, which is our community assessment. All right, so chapter 12, again, that's your community assessment and evaluation. So the objective here is to pretty much understand what is a community assessment, why is it important, and why do we do it as nurses? So what is a community, right? When you think of community, the three things that I want you to remember is people, place, and function. All right, so first, the community is made up of people. These are the residents, the people who live there. Then I want you to think of the place in terms of geography, right? So is it a city, a state, a country, whatever the place, whatever it is. And then the function. What are the aims and the activities of the community? What are their goals? What is it that they like to do as a community together? So when we're talking about the community, there's three common characteristics that I want you to remember: status, structure, and process. Okay, status pretty much, and if you think about the terms, you'll relate it to how I'm going to explain it to you. So the status is basically the current state of the community. Particularly, we're kind of looking at the health state, right? And that is combined up of physical state, the emotional state, and the social state, right? These are usually things that you can find like online, like numbers, like statistics. So the morbidity and mortality rates, right? When I say morbidity, I mean disease, right? So what are the rates of disease? Mortality, death. What are the rates of death? Disease and death, basically. Are the community members, are they satisfied with the community that they're living in? What are the crime rates, of that community? All those things make up the status of a community. Then we have the structure. These are the services and the resources that are available in your community. Again, this is something that you'll take note of when you do your community assessment in clinical. So what facilities are available? Like hospitals, nursing homes, schools, recreational centers, parks. Those are the kinds of things that make up a community, right? And these are the kinds of things that you want in your community. You want to have a variety of different places that people can go to. You don't want to have to go to the next town over, just to go to the grocery store or to go to a park with your kids and things like that. And then also the process. How involved are the community members and their community partners? And how is their relationship? How do they interact and function with one another? And if there is a problem in the community, how is it solved? What is the process that they use to take care of those kinds of things? So remember your status, your structure, and your process when you're thinking about a community. Healthy People 2020. I'm sure you guys have heard about Healthy People. They've been doing this, I think, since 2000, if I'm not mistaken. No, sorry, started in 1979. They started it in the 80s, and it's updated every 10 years. Basically, what they do is they create national health goals based on scientific data and trends. So they're looking at what's going on currently And if there's any problems, then they come up with a plan on how they're going to fix it over the next 10 years. Okay. This is something in your textbook that will come up. You'll see a little box every so often, and it'll tell you what are the Healthy People 2020 goals. I know we're already in 2020, but what are the goals for each population that we discuss in your textbook? Community partnerships. This is the active participation and involvement of the community and the people who represent the community, and how they work together to bring about helpful change. This is something that's very important whenever you're trying to get something done. Partnering up with people in the community and even outside of the community is going to be very important. If you're trying to implement any kind of new program or anything like that to help the residents of that community. All right, so now we're moving on to the community-focused nursing process, right? So again, I remember I told you that in nursing, when you're doing your individual assessment, you guys remember ADPI. So this is it here for the community. So when we're doing our data collection, right, there's a couple of different ways that we can do it. We have direct data. This is data that you as the nurse is going to formulate. You're going to come up with this data, right? So the first one is informant interviews. I think I'm going to do a quick video for you on this as well, because this is another concept that's going to be coming up quite frequently throughout the course and on your exams. So informant interview, all right, this is when you're interviewing people in the community. The reason why you want to interview people in the community is you want what's called qualitative data. You want data that tells you what are the values and the beliefs of these people, right? So we're not necessarily looking for numbers. Numbers you can find in the second type of data we're going to talk about. This kind of data is you're looking for, you just want to talk to them and kind of get a feel of the community, right? This is sometimes is the least favorable one, just because it can be time consuming, because it's an interview, right? And you'd have to interview, you don't just want to talk to one person, you want to talk to a number of people within the community to get different viewpoints, because not everybody's going to look at things the same. When you're talking about informant interviews, there's also something that's called, or someone that's called a key informant, right? A key informant is someone who has a little bit of status in the community, right? They may have a formal title, they may not have a formal title, but these are the people that are connected to the community. They always know what's going on. They could be a politician or a police officer, but they, like I said, they don't have to necessarily have a title. There are those people, you know, like when they have like the community town halls and things like that, they're always in attendance, they always know what's going on. Those are the kind of people that would be a key informant. Remember that. Another type,
I'm sorry, Professor. So those would be the type of people that you would want to interview, like the key informants?
You want to interview other people too. So you don't only want to interview key informants, but they are a good source of information, key informants. They also can help you with what's called, if you're ever trying to do research or trying to do something, there's someone who's called a gatekeeper. Sometimes the key informant could be like a gatekeeper. That's that person that you need to make good with to kind of get you in to where you need to go with whatever it is that you're trying to do. So you don't only want to talk to the key informant, but it's good to talk to one. But it's okay, and you should talk to other people in the community too, because you want a variety of perspectives. Okay. And then the second one is participant observation. This one requires you to just observe, right? So you can go to any kind of community gathering. Maybe you might attend a church service, you might go to the grocery store, you might go to a health fair. You just want to kind of get a feel of how the people in the community operate. So here you're just observing and you're just watching how the people move and operate in the community. Then you have a windshield survey. The windshield survey is what's called a motorized version of the participant observation. And it's called motorized because you're either going to be like in your own car driving around, or you could do it on a bus. Most people do it in their own car though. So basically what you're doing is, let's say you're working, you know, in a city in Miami, and you want to know a little bit more about it. Maybe, you know, you think that there's a need in the program, in the community, that you want to address. You want to do something about it. The first thing you need to do is your windshield survey, right? This is your assessment. So you get in your car and you drive around and you're looking and you're saying, okay, they have this, they have that, right? These are how many schools that they have, you know, in the area. These are how many bus stops they have. You know, how frequent does the bus run? What are the types of people, you know, what do they look like, the people who are going on the bus? Are they older? Are they younger? Are there a lot of people walking around? Is there a lot of people loitering? Are there playgrounds? If there are playgrounds, how do they look? Are they well kept? You know, are they closed? Are they accessible to the community? How far away is the nearest grocery store, you know, to the residential areas? You know, those are the kinds of things that you're looking at. You're looking to see if there's any graffiti, is there any litter, just overall, anything that you can see, you wanna document it and look at it. And the reason why we're doing this again is because we want to see if there's any gaps or any needs in the community that we may need to address. You also want to do your windshield survey once in the daytime and then again in the not in the afternoon, like in the evening or at night, if it's safe to do so. Because you want to see what the community looks like in the daytime, and you want to see what it looks like, you know, later on when people get off of work, when people get off from school, because it can look completely different. And that's also a good idea too. Like if you're ever moving to a new area, you always want to check out the community in the daytime and in the nighttime as well, because again, it can be very different, you know, than it is in the day. So those are the three types of direct data: informant interview, participant observation, and windshield survey. Those are the types of data that you as the nurse is generating. Then you have the collection of reported data. So reported data is basically data that's already been made, and basically you just go and you find it. Either you can go online, if you're doing like a more of a scholarly search, they have databases that you can do to find that information. And basically what you're looking for are things like statistics, morbidity, mortality rates. Maybe you could even look at the minutes from a community meeting. Anything that's already typed up and published, anything like that, any sort of surveys that might have been done previously, those are the kinds of information that are secondary or reported data. So again, primary data or direct data is the data that you as the nurse, you're generating that information. And then the secondary or reported data is data that already exists and you're pulling that up. Most of the time, these are things that you can find online. Okay. Any question about that? Okay. So after you've done your assessment, the next thing that you're going to do, right, from your assessment is you're going to identify or diagnose, right? So this is your ADPI, this is the D, the diagnose, but they use the term identify. So you're going to identify any community problems that you think needs to be addressed. So whether that be, you know, the park that you looked at is not safe for children to play in, and that's something that you want to tackle, you want to address that, go for it. After you do your diagnosis, then you're going to plan what it is that you're going to do. So you're going to analyze the problem, prioritize it, establish your goals and objectives, and then you're going to identify what interventions you're going to do. Okay. The difference between a goal and an objective, I don't know if I think this probably comes up in a later chapter, but I'll explain it now since it's here. So a goal is something that is very broad, right? It's something that you want to accomplish. So let's say, going back to the park thing, you wanted to make the park safe for the children to play in, right? That's a very broad goal. You could do anything with that. Your objectives are going to be the things that are going to help you meet that goal. So what are you going to do? What are the steps that you're going to take in order to make sure that the playground is safe for the children? Okay. So we've done assessment, we've diagnosed, we've planned. Now it's time for us to implement whatever it is, right? I don't really have much to say about that because pretty much your implementation is basically you doing whatever it was that you planned, right? You're going to do the things that you said that you were going to do. And then evaluation. At the end of everything, you want to evaluate and see what you implemented. Was it effective? How was it received by the community? Another thing that I want to make sure that you understand before you, even though you've done your assessment and you've diagnosed the problem, you always want to make sure, and again, this is where the informant interviews, the key informants, and the gatekeepers come in. You want to make sure that the community is on board with what it is that you're doing, because you don't want to waste your time doing a big project and then the community is like, we don't want this. This isn't what we wanted. We need to focus on this. This is our priority. So you always want to make sure that when you're working with the community, that they're on board with what it is that you want to do. All right, and then finally, personal safety. So you're going into a community, especially if it's one that you're not familiar with, you don't live there. Remember that your personal safety is a priority, right? So keep these things in mind. You may want to go with someone, another nurse. You know, a lot of times it's not advisable to go by yourself. So if you have another nurse that can go with you, bring them along as well. Okay. Any questions about community assessment? Okay. I'm going to show you, and I'm going to post this on doc sharing as well. It's just a little like a checklist. So it's like a little survey tool that you can use, and you can make your notes here while you're doing your windshield survey. So what you're looking at, you know, the bound, it has a lot of stuff on here, but you can look at the boundaries to see, okay, where does this place begin? Where does it end? How old are the houses? Are they single family homes, multifamily homes, apartments? Are there any signs of decay? Are there any parks and recreational areas for the children? Any common areas where people kind of like hang out? What about the stores? Do you have any grocery stores, retail stores, pharmacies? Transportation, how do people get around? How do people communicate? What else? Any kind of service centers there, like healthcare, social services, school, employment offices, people in the community, who's in the area during the day? What kind of evidence is there of any kind of classes, right? We know in certain areas, right, some sections are day and night. Some are, you know, more upper class, middle class. So that's another thing to take note of. Is there an industrial area? You know, is there any kind of like factories or warehouses or anything like that in the area? Any protective services? How far is the nearest fire station, police station? Those are important things. Ethnicity, what is the predominant ethnic group? You know, this has to do with culture. Religion, when you're looking at the churches, right? A lot of times you'll be in a community and you'll see a lot of different churches, but if you take note, they're different denominations. So that'll give you a kind of clue of to who you're servicing in the community as well. Okay. So again, I'm going to post this in doc sharing. Any questions again on community health, community assessment? Okay. So what I want you guys to do, I'm going to break you up into groups. I have two breakout sessions for you. The first one is I want you to go to, this website. I'm going to post it in the chat. It's the Florida Department of Health website. And I'm going to assign to you next week. All right. So all right, so here I just want to go over some of community health nursing theories. Don't worry about systems thinking and upstream thinking, but I'm going to just explain it to you just so you understand what it is. So systems thinking is when you're thinking of different, how individuals and different systems and units interact in terms of health and the relationships there. So when we're looking at something, we're not just looking at one thing or this thing, we're looking at how everything kind of like interconnects and causes things within our health system. Upstream thinking is when we're more so focused on preventative health rather than
thinking about medicine or treatment after somebody has a disease, right? So upstream thinking is just like we're thinking ahead. How can we prevent this from happening? Versus medical treatment, where it's like we're gonna do something about it after the fact, right? And when you think about it, that's pretty much what public health is. The goal is basically prevention. But like I said, don't worry about those. I just wanted to explain them to you because they are in your text. What I do want you to focus on are these theories here. So you should know already Nightingale's environmental theory, but just to refresh, remember basically she kind of was the one who established that everyone needs, a clean environment, fresh air, those kinds of things. Aside from the medical assistance that they need those kinds of things to help them, to help them recover. And she kind of established this when she was in the Crimean War. She was a nurse there. And she basically helped a lot of the soldiers to recover based on that simple environmental theory. Then we have the health belief model. The health belief model, when you actually look at the model, it can seem kind of convoluted and confusing, but basically the whole purpose of it is to predict and explain the health behaviors of people, right? So what it looks at, it takes into account how the person feels about uh, how how um, how susceptible they are to getting a disease, right? So whether or not they believe that they could get the disease. So for example, if someone believes that they're going to get diabetes or not, how do they perceive it? Do they perceive it as a serious threat, or are they just like, I don't think that's ever going to happen to me? We're also looking at some of the other things like their demographics, right? And their knowledge level as far as what they understand about the disease. Other things that we're looking at, cues to action. So basically, what are some of the things around them in their environment that are going to help them to make a decision whether or not they need to change their behavior? Whether that be the media, sometimes we know that there are certain diseases that are like hot in the media that everybody's talking about. Whether that be they're going to take advice from the recommendations of their family and friends or healthcare providers. The other thing that we look at is basically how they see it. What is the benefit of them making this change, right? So for example, if we have a patient who is diabetic and we're telling them that they need to cut back on their sugar intake, so they're going to consider, well, what's the benefit of that for me? And then they're also going to consider what are the barriers. What if they don't have access to the kinds of foods that we're telling them that they need to eat? What if the kinds of foods that they have access to are the kinds of foods that are, filled with sugar? So they're kind of looking at the benefits of them taking the advice that you're giving them versus the kind of barriers that they're going to meet in their day-to-day life. Any questions on health belief model? What I really just want you to get from that is the purpose of the model, and it's just basically to help us kind of predict or explain the health behaviors of our clients. Again, the model does have, a breakdown, and I said it can get a little convoluted and confusing, but as long as you understand what it's used for, the purpose, then you should be fine. Then we have Milio's framework for prevention, right? This is similar to the health belief model, but the health belief model we use on an individual basis, right? So if we're working one-on-one with a patient, we would use the health belief model. Now, if we're assessing a community, then we would use Milio's framework for prevention. It basically has the same concepts, but just on a broader level. Then there is Pender's health promotion model. It's also similar to the health belief model, except that it doesn't consider health risk as a factor to basically make the person want to change. Okay. Any questions on any of those models? Okay. All right. And then finally, we have the trans-theoretical stages of change model. So this model here kind of tells us where our patient is in their change process, right? So we have pre-contemplation. Pre-contemplation is just what it is. It's before they are aware that they need to change, before they start thinking about the fact that they need to change. Then we have contemplation. This is where the person actually starts considering whether or not, excuse me for a second. I need to get a drink of water. I'll be right back. Oh, I'm sorry. I had a tickle in my throat that I was trying to ignore, and it was not going away. All right. Give me one. All right, sorry. So pre-contemplation is when the individual is unaware that they need to change. So this is before they start thinking, hence the term pre-contemplation. Then we have contemplation. This is where the individual actually starts thinking about the change that they need to make. So now they're aware. They know that there's an issue, they know that there's a problem, and they start thinking about, well, what are the benefits of me doing this? What are the costs of me doing this? They're thinking about all the things that you would usually think about before you make a decision, right? Then there's preparation. So this is when the person has done the thinking and they're like, okay, I think this is something that I want to do, and they actually plan to take action. And they actually start taking the steps that they need to take before they actually do it, right? So an example of this would be someone who decides that they want to start working out regularly, right? So they may make the investment to, buy running shoes or workout clothes, or they might make the investment to purchase a treadmill, or even it doesn't even have to be something that costs money. Maybe they've put together a group of like-minded individuals, and they say that they're going to meet up every so often, to run or work out. So they're making the preparations that they need in order for them to actually execute their plan. Then there's action, which is self-explanatory. This is when they actually do the thing that they said that they wanted to do, right? Then there's maintenance. This is when the person is continually doing the thing that they said that they're going to do. So again, going back to working out or running, they've been doing it on a consistent basis, but it's been more than 6 months, right? So they've been doing it continuously without interruption. They haven't fallen off the bandwagon. And then there is termination. This is when the person is basically, they no longer have to make a conscious effort to do it. It's just something that becomes a part of them. It's a part of their lifestyle, and it's something that they do all the time. Unfortunately, most people never really reach that point. At some point in their life or their journey, life happens, they fall off the bandwagon, and then, they either start back at the top, whether it be not necessarily pre-contemplation, it would be contemplation if it's this thing, or if it's something else that they've decided to take on, then they'll start at pre-contemplation. Anybody have any questions on the trans-theoretical model? I think I have some pictures of the model. Sometimes it helps when you see something. So if I can find that, I will post it on Blackboard. Okay, another term that you should be familiar with is determinants of health, right? So these are the things that include like nutrition, your education level, where you live, those kinds of things. Basically kind of like socioeconomic factors, your employment, those kinds of things. What else should you be familiar with? We already talked about assessment, policy development, and assurance. make sure that you understand that. It's in your Stanhope text as well as here in ATI. I like how it is in ATI, it gives you those quick bullets. So I think that will help you to be able to digest it a little bit better. We already talked about community-oriented nursing and community-based nursing, but I will recap it because it's something that's going to continue to come up. So remember, with community-oriented, we're working with the population, right? The larger population, we're working with more people. We're focused on health promotion and disease prevention. We're usually working with the people indirect, but we can work with them directly if need be. And then in community-based nursing, we're working with individuals and families only. We're managing acute and chronic conditions, right? So we're managing diseases. The care is direct, it is one-on-one, okay? Let's see. All right, here they have some really good examples of primary, secondary, and tertiary prevention. So be sure to go over that as well. Okay, so I'm going to stop right there. Does anybody have any questions on anything that we covered today? Okay, so if not, we do have a classroom assignment that you guys are going to have on a weekly basis. I did post it on Doc Sharing. So if you go to Doc Sharing, you look, it'll be under week 1 classroom assignment. So you'll work on that now, and then you'll need to submit that to me via Blackboard. Send it as a message. Don't post it on Doc Sharing or send it to my Outlook email. Make sure you send it to me via the email in Blackboard. And that goes towards your active engagement points. You know, you get 30 points for participating in class, right? So when you complete those, send them to me. That's why I give you time in class to complete it. For the most part, you should be able to complete most, if not all of it in class. So just go ahead and get started on that now. You don't have to send it to me tonight. Again, you send it, we have class on Wednesday, so you have to send it to me by Sunday midnight, okay? But I recommend trying to do it now so you don't have to worry about that later on.
This is Roz. What's the name of the assignment in Blackboard again?
It's week 1 classroom assignment, but you're gonna find it under Doc Sharing. You're not gonna find it under assignments.
Professor, can we type it, both of them? Because the first one, one of them, it says it has to be handwritten.
Yeah, so the one that has to be handwritten, I want you to write it. The other
Okay.
one, you can type it up if you want to.
Okay.
All right, if you have any questions while you're working on it, like if there's a question that pops up that you're not too sure about, just go ahead and unmute yourself and ask me and I'll help you out with it, okay? Also, essentially what the classroom assignments are, they basically help you create a study guide, right? So remember I was telling you that you should be spending at least 10 to 15 hours a week, you know, studying and preparing for the class. This is a part of that. So if you do it now, then you have basically something that you can use in addition to your text. Obviously, I wouldn't tell you that you should only study this because there may be other things on your exam. But essentially, this will help you prepare for the majority of what you're going to encounter on your first exam, okay? do is an assessment in the home. So what are some things we're looking for in terms of safety that we want to make sure that they have or they're not doing, those kinds of things?
Make sure that they have rails in their bathtubs to hold on, making sure there's
Hmm.
no like cords on the floor or loose or like throw rugs that they can trip over.
Hmm.
That they have accessibility to their like assisted devices if they use any. Um, Sometimes if they
What's
have
something else they should, what's something else they should have in the bathroom if they need it? Not all elderly are going to need it, but you said handrails. What's another thing they should probably have?
A shower chair.
Mhm. Perfect. Shower chair. And also raised toilet seats, right? A common issue that we don't think about is sometimes the toilets are so low, like even, for people who are not, that old. And when you're that elderly and you sit down so low, sometimes you have a problem getting back up. So raised toilet seats, shower chair, handrails in the shower. Perfect. You said no throw rugs. That's good. If they do have rugs, just be sure that it has rubber backing, that it's not like bunched up. Sometimes it'll get bunched up around the edges and you can trip over that. Cords should be run along the wall, behind furniture, not in the middle. Lighting is also something that they need to make sure that the lighting is good. So that way they can see that there's no clutter on the floor. There's not, if they live with family members, that there's not like, little kids' toys thrown around and stuff like that. What about the water temperature? This is for elderly and for like if you have small children too. What's the temperature that the water should be on max? Yes, no more than 120. So if you see anything greater than that, then that's a potential for a burn. Pay attention to questions. Sometimes it'll ask you, sometimes you think it's the right answer and we're looking for the wrong answer. Those kinds of questions where it'll say which one is not or the least effective, and then you choose the one that is effective. So make sure you're paying attention to those. We talked about lead already. I forgot who had it, but you said I think what you found for the CDC was 45 is the number where we start doing treatment. Just know that lab values vary, but they don't usually vary too much. So if you may not see 45, but you may see another number in the 40s. So just remember that in terms of when we start treatment. Another lab value for lead is the number. Think of the number may not be high enough for us to initiate treatment. So if they have anything that's like maybe a 4, somewhere around that range, we would just tell them to come back within maybe 6 months or year time and be tested again. Okay. So there's certain levels where we're just going to monitor and retest. And then when it gets to that number in the 40s, that's when we need to initiate treatment. There is really no acceptable number for lead. These are just kind of like guidelines that we use because really we don't want any lead detected in the blood. All right, what is a resource that we can use for people in the community that may not have access to food? Maybe they have a disability where they cannot prepare their own meals. What's a service that we can use in the community? Have you ever heard of Meals on Wheels? So Meals on Wheels is a service in the community. Some communities may have a service. It may not be called Meals on Wheels, but they have different services in the community that will deliver meals specifically to people who are elderly. They're meals that just pretty much just need to be like microwaved or heated up to prevent them, from basically not having food. So just remember that. Who can tell me a little bit about herpes zoster, aka shingles? Mhm. 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 And how does it present? What does it look like? What does it feel like? Mm-hmm. 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 Yeah, it doesn't cross the midline. So usually you'll see it'll be like on the side of people, but it usually doesn't cross over like the middle of your body. What else?
There's a
So it is
vaccine.
very painful. There is a vaccine for it. We give it to people who are in their 60s. I don't remember the exact age. Um, and it is very painful. Even after you're healed, some people will still experience pain. It really just depends. Not everybody is the same, but that is something that can happen. They can have pain for a while after the lesions have resolved. Okay.
Adults 50 years or older.
hmm I'm not sure if it depends on the insurance too. I'm not sure if they're covering it because like the pneumococcal vaccine, insurances will cover that. But the shingles vaccine, I think is kind of it's not really new, but it is. It's just one of those things where insurance companies are not really covering it quite yet, but we do recommend people to get it if they can get it. If you have a patient that is compromised, what kind of hand hygiene do you need to do? We're washing with soap and water, but a special kind of soap. We're washing with chlorhexidine. Remember that, chlorhexidine. All right. Who can tell me, how does emphysema present? If you see a patient with emphysema, what are the classic textbook symptoms?
Narrow chest.
Mm-hmm. Perfect. What else?
Tripod position.
Mm-hmm. Mm-hmm. How do their fingers look?
Clubbing.
Mm-hmm.
The
Clubbed, right?
fingers, they're cyanotic, vocabulary refill.
Mm-hmm. Dyspnea. Perfect. All right. Okay. What about hypoglycemia? How do we expect that to look?
They're gonna be shaky, diaphoresis.
Mm-hmm. Right. Sweating. All right. Good. So yeah, diaphoretic, sweating, clammy, right? Blurred vision. Okay. Let's see. Also tachycardic as well. All right. Do you guys understand or have you reviewed yet modifiable versus non-modifiable risk factors? Right? So we know that modifiable things you can modify, things you can change. So your diet, your lifestyle, things you cannot change are like your biological sex, your genetics. What else? There's a lot of stuff that I usually think. Your age is one of them. We can't change our increasing age, but we can change other things. Again, like your sedentary lifestyle, your diet, and things like that. One thing that some people get confused is you cannot change the diagnosis, obviously. So if you have diabetes, you can't change that. But you can change your outcomes in terms of like the numbers associated with your diabetes. So like your A1C, your blood sugar, your blood pressure, things like that you can change. We don't have much time. We don't have any time left, actually. That was it. Okay. So before I let you go, chapter 2 is supposed to be a part of today. But a lot of it is just the history of public health, which is important, but it's not something that I'm going to test you on. So I do want you to review the chapter, understand the history of it, but don't worry about that you'll be tested on it. I did want to bring to your attention, I'm sorry I didn't bring it up earlier, I completely forgot about ATI. So in your ATI for this one, passing score is 74%. Okay, so I know that's a little bit higher than what you guys have been used to so far, but you need at least a 74% in order to get a level 2. So we're going to be working really hard, you know, this term to make sure that everybody can accomplish at least a level 2. Can you guys hear me? Because my stuff is showing that I'm unstable. Okay. All right. Group. Perfect. There's a group project that you guys will have to do if you saw in the syllabus for vulnerable populations. I will be choosing the groups and the topic that you're going to be doing. And I'll post that tomorrow under Blackboard announcements. And then finally, we have group tutoring tomorrow at 6 o'clock. So I hope to see as many of you there as possible. Okay, we'll go over what we did today and make sure that you're prepared for your exam next week. All right, if you can't make it to group tutoring, then just send me a message. If you want to do one-on-one tutoring, just let me know. Okay.
All right. Thank you.
All right, you're welcome. You guys have a good night. Remember to sign out, okay?
Good night.
Thank you. Good night.
Good night. Thank you, Professor.
Good night. Bye.